For everyone who has joined and also is joining right now, good afternoon. Very welcome to today's webinar. And this is Yue from GE Healthcare. And we have the honor today to have Dr. Maria Ruediger with us. And Dr. Ruediger is the Senior Full Professor for Fetal Neonatal Health. He is also the Director of the Saxony Center for Fetal Neonatal Health at the Technical University Dresden and head of the Department for Neonatology and Pediatric Intensive Care Medicine at the Children's Clinic of the University Carl Gustav Karras in Dresden. So he will be with us today addressing the topic of stress and preterm birth, understanding and alleviating impacts on infant development. And as most of you know, the stress there in NICU environment is real, not only for the little patient, but also for the caregivers and parents and families in different level. So before we start, please allow me to do a short housekeeping here. This session will be recorded and shared with all the registrants, but some contents will be edited out due to regulation consideration. So for all of you who joined here live, have the privilege to get the full information and interact with Dr. Ruediger during the session. So don't hesitate to post your questions or comments using the Q&A function, or even unmute yourself to participate in the discussion after the speech. So now the floor is yours. I pass it over to you, Dr. Ruediger. Thanks a lot.
So thank you very much for the very nice introduction and kind introduction. It's a great pleasure to be a host or be invited to this webinar. And I'm going to start my presentation, and I think it's going to work because we have tried it before. And
yes, we'll see you well.
Yes, you can see it. Yes. As you already introduced, we are going to talk about stress and preterm birth. And I will have also a few questions during the webinar. But let's start with a short notice concerning potential conflict of interest. So I'm a member of the ERC guidelines and ILCOR, and I'm also support the German Foundation for Sick Newborn, where we published a paper or a book about this, but it's in German. And finally, I support the European School of Neonatology. And if you don't know the European School of Neonatology, you can listen to the podcast Neonatology Now. And there's a very nice series with Dr. Wolke. I discussed many topics I'm going to discuss today. And so you're invited to have this one, to listen to this one as well. And finally, I received some speakers honorar from different companies. And of course, I get some payment from healthcare. GE Healthcare for this presentation as well. But let's start with a very short look back. Let us look back about 120 years ago, because you see on this book, you see my little daughter, and she is in a bathing position. And I will repeat this topic of bathing position very often, and I will show you bathing is not the same like bathing. And so I will start with a bathing situation about 150 years ago, and you will see that that's very different when babies were bathed. You see, that was mainly about getting babies clean, getting babies nicely equipped, but it's not about some situation where the baby feels well. You see the baby is in stress. But that was old time. And if you look back in old times, that was a situation 40 years ago where there was almost no equipment, no incubator, and so on. And the problem was that many babies were dying. You see the admission book, and so you see many babies were dying after being admitted to the NICU. That has changed. Mortality of newborn babies has significantly reduced over the years. And if you are talking nowadays about mortality, we are talking about mortality which is between 1 and 3 in 1,000 newborns in Germany. We have some differentiation, and here that's Germany, and you can see Saxony is down here where I'm working, so we have one of the lowest mortalities. But still, we do have a problem, and we do have a problem not with mortality. Even in the very, very preterm babies, mortality is reducing. If you look at the mortality of preterm babies below 1,000 grams, we have less than 5% of these babies are dying today, but we do have a problem with outcome. And the main outcome we do have a problem with is neurological development. And if you look at neurological development, there's a very nice study published by Dieter Wolke, where he looked on the long-term outcome. It's a Bavarian longitudinal study. And he was looking at infants after 26 years after birth. And he was comparing these preterm babies with term babies. And as you see, preterm babies are always worse than term babies. But you see also three different groups. And these three different groups have one important point that is differentiating both these three groups. And that's the socioeconomic status of his families. And socioeconomic status does not only mean money, but it also means how parents interact with their baby. And you see a preterm baby can develop as good if you have a very high socioeconomic status as a term baby, which has a low socioeconomic status. And that's an important aspect I want to discuss with you today. And so after giving you this problem and showing or trying to convince you that the main problem nowadays is a neurodevelopmental outcome, I will also give you some background information about neurodevelopmental outcome. But initially, we will start with our first question. And if you could pose the first question, that would be very nice. We will try whether it works.
Yes, the question is launched.
Yes, excellent. And so I'm going to ask you, which of the following stressors do you find least important? That's important, least important for subsequent development of extremely preterm infants. And maybe just one question, you just choose one question, which you consider as least important. You just have to tick. And so there's nothing wrong or right, but I'm just interested what you consider the least important stressor for subsequent development of extremely preterm infants. Okay. So you have to look whether it has been answered.
Yes.
Okay.
Are you able to see?
No.
Oh, you're not. Okay, so we've already have 18 answers there. And answers are quite various. I will wait for a little bit more time. Still, people are answering. So I'll give them more time before ending the poll.
Okay.
Still, some of you haven't answered yet, but we have 70%. Okay, 73% of the participate has answered. So is our time okay?
Yep.
Okay. Okay, so most of them have answered, so I'll end the poll for the sake of time.
Just show.
Mm-hmm.
Yeah. So you consider the random exposure to different caregivers during the first days as the least important aspect. And the most important seems to be, skin to skin. That's very good. Okay, I will cover some of these aspects in my talk. And let's have a look at the background. So if you think about the normal fetal neonatal development, there is a long part, 40 weeks, where you have fetal development within the uterus. And that fetal development is very well programmed, and I will show you some details of this one. Afterwards, you have the delivery or birth, and that's very important to get these very close relation with the parents. And you have the newborn, and subsequently, you have, if you're lucky, a healthy infant or a healthy adult. But there could be some problems. And if you look at the problems which are affecting neurocognitive outcome, you have two aspects which are very important for neurocognitive outcome. One is the so-called hardware, so somatic determinants. That means if you have a bleeding, if you have a stroke or so, you have a problem. However, that significance of this problem is initially, but over time, it's getting less important. Over time, which is much more important, are the psychosocial determinants. That means you lay the basis for this one, for the parent-child interaction very early, but the effect you see on the long time very much, as I've shown you by the data from Dieter Wolke. So, and if you look at the usual way of neurocognition, you have prenatally, you have many processes which are taking place. Initially, the baby is experiencing some oscillations. The baby learns that environment can change. Then the baby also detects some consistency. That means during nighttime, it's quiet. During daytime, it's getting more active and so on. And then the baby finally, at the end of the pregnancy, also learns if I kind of hit against the stomach or against the belly of the mother, then I get some response. So it realizes self-efficiency. So if I do something, I also can get an answer. And so the baby starts to explore everything, how it can get an answer. Then after birth, it's very important to have the morphological determinants. So it needs a sensory system, so it can look, it can smell, it can hear, but nerve conductivity is important. Breathing, circulation is very important. If breathing is not stable or circulation is not stable, then the baby has no time or no energy to learn something. And finally, the environment is important. If we give analgesic sedation, variants of contact and so on, pain, stressors, it's not very good to learn or to have a good neurocognition. And if you look at these normal fetal development, you can have some impact in utero. You can have maternal infection, but you have also stressors which affect subsequent neurodevelopmental outcome of the baby. You can have a normal intrauterine fetal development, but if the baby is born too early, you have the extrauterine part of fetal development is disturbed, or you can have like infants with the small for gestation, growth retardation, they have a disturbed intrauterine fetal development, and they are also born very early sometimes, and they have a disturbed extrauterine fetal development. And so you can also have an impact after birth. So if you're born at term and you have some problems, then you can have a problem. And these are causes which cause long-term deterioration in neurodevelopmental outcome. And I want to discuss some of these aspects. Initially, I want to discuss with you the part of intrauterine problems which could affect the infant's development. And if we look at these fetal development in utero, we have some aspects which should be considered. And one aspect, the topic of today, is parental stress. Even during an uneventful pregnancy, usually uneventful pregnancy, if the mother has stress, it can cause problems with the baby. And there's a very nice study I wrote with you for you, and that was performed in Washington, D.C. And they were looking at pregnant women over a time period for 2014 to 2019. We're measuring the stress in these pregnant women, and we're looking at the MRI after birth. And then COVID came, and they said, okay, we can repeat this one as a testing. And during COVID, it's most likely that women have more stress, and then we see the impact of stress. And they could include about 159 mother-infant diets. That means about 100, they were born before COVID, and about 50 which were born during pandemic. And they measured or tested the mother for stress, and then at a gestational age or 2 weeks, about 2 weeks or 3 weeks after delivery, they put the baby in the MRI, and they're looking at the MRI. And they found, first, there was, if you compare pre-pandemic and pandemic cohort, in the pandemic cohort, you have much more, about 2/3 of pregnant women, which show signs of anxiety. You have more than 2/3 of women which are positive scored for stress. And you have almost 3/4 of women which are above psychological distress. So that means pandemic was a real stressor for pregnant women. That has been repeated in several other publications as well. But then they were looking at the MRI. And what they found in the MRI, and they compared infants with low maternal stress and high maternal stress, they found white matter as much less available, or the white matter is much smaller, the amount of white matter is much smaller. And if there was maternal stress, there is the right hippocampus, much smaller if there is maternal stress, and the left amygdala is much smaller if there is maternal stress. So just by having stress to the mother, to a pregnant woman, causes deterioration and morphology in the MRI of the brain. That has been repeated by several other studies. Here's a very nice, very recent review of several publications which show that maternal stress during pregnancy has a big impact on the neonatal or fetal brain. And there's also, if you have maternal depression, you have an impact on hippocampal connectivity. And you also have maternal depression is associated with fiber diffusivity. So the fibers are not as good developed as without maternal depression. And the fibers are very important for subsequent cognitive development. And you also have, if you just have a few stressful events, if you don't have just entire period, but you have few stressful events, you have effects in the MRI as well. And so I would like to conclude, and that's very important for daily practice, that if you take care of a pregnant woman, you have to ask for maternal stress or depression. Maybe you even use a scoring system for maternal stress or depression or other stressors during pregnancy, because diagnosing fatal problems can also cause stress to the family. So if the mother goes to the prenatal service and learns that the baby has a diaphragmatic hernia or any other stressors, any other diseases, that will cause stress with the mother. And in addition to the disease of the fetus, the stress of the mother will also cause disturbances in brain development. And if you know you have a pregnant woman with stress, if you screen them, you should provide psychological support. And you should also provide psychological support if you are diagnosing fetal problems. So in my clinic, it has become standard. If the obstetrician is talking to a woman and telling her, okay, you have a baby with congenital heart disease or anything like that, then the mother gets psychological support. You have to provide information and you have to involve the entire family. I think that's a very important message. Coming to the next one, the major topic of today, fetal development ex utero. So that means what happens with our preterm babies if they are born too early. What does it mean to the fetal development which takes place ex utero? And if you have the next poll, then it would be the perfect time to have the next poll. Excellent. So initially I was asking what you think least important, and now I'm asking which of the following interventions have been implemented in your NICU. So that means, what are you doing to prevent stress? Do you have a protocol to reduce pain, policy to reduce invasive ventilation, ensure skin-to-skin contact, reduce noise and light exposure, or you have a dedicated psychosocial support program?
Okay, we're getting answers.
Excellent.
Wait a little bit.
Yeah.
Okay, we have more than half of the participants answered. See some hesitation here.
Okay. So there's a reason for hesitation. You don't get punished. You just I want to learn what you are doing. Okay.
Okay, so not all yet, but I'll close the poll here for the sake of time.
Yep.
Here's the result.
Okay. Well, that's very well equipped. Oh, ensure skin-to-skin contact. That's very good. So I'm surprised because very often that is not really the case in every. Excellent. Okay, then we will continue. So if we look at the fetal development in utero, then we can have the situation where we have some which have disturbed fetal development anyway, or babies who are born preterm and then are exposed to the situation ex utero, which is not normal for the fetal development. And if you remember these aspects, which I have shown you before of normal development, and you think about this chance of exploration or behavioral coordination, so the baby is pushing to the belly, gets some response, baby cannot do this outside of the body. Or if you think about the normal birth, so it very often you don't have the early bonding. In your case, most of you have the early bonding of the very preterm baby. Or if a baby is almost dying because it had bradycardia or poor saturation, then there's no chance to activate the sensory system. Or if you analgosedate the baby, then there's no chance to learn. So there are many, many different aspects which interfere with the normal fetal-neonatal development and which potentially impair neurocognition. And so let's talk about pain. So if you are talking about stress in a preterm baby, actually everybody is saying pain is a problem. So, but what is a real, how often are babies exposed to pain? And there's a very nice, very recent publication, also 24, where they looked at the painful procedures and they looked in different publications and they were considering maybe old publications. So before 2012, there were much more pain than nowadays. And what they found was per day, the preterm baby is exposed to about 9 painful procedures. Every day, about 9 painful procedures. And now you are asking, oh, we are getting much better nowadays. We don't have so many painful procedures because we have learned it. But I have to disappoint you. If you see nowadays, it is still after 2030, we have just 2 painful procedures per day less. Still, we have about 7 painful procedures per day. No, 6.4. Sorry, I mixed this up. If you take everything together. So we have about 3 painful procedures less than 10 years ago, but it's still 6.5 painful procedures is quite a lot. And there were different painful procedures. And if you're just looking at the needle sticks for blood gases or anything, then we have to say also there is no improvement over time. The daily needle experience is about every second day, the baby experienced 1 needle puncture. It was up until 2012. And nowadays, it's the same. There is no big change in this one about the daily needle experience. We are not getting better. And I'm really questioning whether that's really necessary. Because if you look at some studies, some publications, there's just 0.1 needle experience per day. And there are other institutions which have 10-fold higher needle experience. And there's no big difference in the population of these patients. So I think it would be worth, if you are checking your needle experience, how often the babies are exposed to needle experience, per day. And if you are here in this range, you should try to get down, and you should consider or ask yourself, for every needle puncture, is it really necessary? Does it really cause a benefit for the baby, or is the stress interfering with brain development? And if you cannot reduce the exposure, then the second question is, how often are we providing procedural pain treatment? And there is also a summary. There are some institutions or publications which have almost no procedural pain treatment. And there are other institutions which are quite good. They have almost for every painful exposure, they have some pain treatment. And I think that should be the goal, up to be up in the higher part. But that's not the reality. It's about just 1/3 of painful procedures are treated nowadays. And so there's a good chance to improve your management about this one. And even more, I was talking about single punctures or single pain events, and even prolonged exposure is a problem. And there are different studies, a scoping review, which covered all the available studies, and they were looking at palliative care surgery, NICU, term-born, extremely preterm, and they looked at different concepts of prolonged pain. And if you want to know more about it, you have to read this scoping review. It's very nice. And the short summary of this paper is prolonged pain exposure plays an important role. Knowledge of key concepts is necessary, so it should be part of education for your nurses, for your doctors. And pain monitoring is crucial to prevent these negative long-term effects. So, talking about pain, we have to say you have to count and monitor your painful procedures in order to learn more how often are babies exposed to pain in your unit. And you should also use a pain scoring system to quantify pain. That should be standard. Every shift, you should look, what is the pain score? Do we need some treatment? And there are many non-pharmacological, but also pharmacological treatments available, and you should have a protocol. You should have a protocol in order to treat pain and to prevent pain. But it's not only about treatment, it's also about preventing. So you should reduce the number of painful procedures. And for instance, my institution, you really count the numbers of needle exposures, of needle punctures, and I can tell you over the time where the problem is and what we have to do. So I was talking about pain, and now feeding mother's milk. Everybody knows feeding mother's milk is beneficial. But if you tell the mother, so the best thing you can do for your baby is provide some milk. So the baby will enjoy it, will benefit from it. It also causes stress to the mother because you put a lot of pressure on her shoulders, and she feels very insufficient if the amount of milk is not sufficient. And so that's very important to consider. Even if you want to do something good, you have to explain to the mother, or you should support the mother by pumping breast. And there's a very nice publication which looked at this one, whether there are some measures where you can help the mother to produce more milk. And they had a very nice review, also a very recent one, and they had 5 studies which looked at lactation-specific guided relaxation, breathing exercises for the mother, music, and the mindfulness app. And the interventions took a few days, up to a few weeks or months even. And there was parents which were expressing milk for sick and preterm babies in the NICU. And there were 16 studies, about 1,800 participants, so the data are quite good. And if you look at the results, you will find, first, if you give this support, you will really increase the quantity of human milk. If you give these, you will also increase the content of carbohydrate of the milk, not only the amount of milk, but also the content of carbohydrate. And you will also have an impact on the infant because infant weight was increased if you provide these interventions. And furthermore, you have some benefits for the mother. You have a reduction in anxiety and you have a reduction in stress if you support lactation for the mother. And so these are very easy interventions, but that the impact is big. So here is a summary. You have an increase in carbohydrate, you have an increase in energy, of course, and in the quantity. You don't have an impact on fat content, and you have benefit for infant growth, for weight and length. You don't have an effect on infant behavior, but you have also maternal association, which is reduced stress and anxiety, and you also have lower or physiological blood pressures. So there are many beneficial effects. So talk to your lactation team and ask whether they have these methods available. So another aspect I would like to discuss with you is positioning of the infant. Positioning of the infant is mainly considered for protecting of skin, but positioning of the infant does also have some impacts. Here again, a recent review on positioning of the infant, which covers about 17 publications of 15 studies, and that concerns the positioning of preterm infants. And the result is prone positioning improves sleep quality and duration and reduces, or the babies had fewer self-regulatory behaviors. Supine positioning, on the other side, increase awakening and activity. So it's very good to have a mixture between prone and supine position. And that means in your unit, you should experience, or infants should experience, a rotational position. If you want to have the baby sleeping, then put it on a prone position. If you want to have a more active baby during several periods of the day, where the baby is awake, can learn anything, put it in a supine position. So, and then the important aspect, skin-to-skin contact. I was very excited that most of you already have skin-to-skin contact in the delivery room of preterm babies. That means you are doing it also in a 400, 500 gram baby. You already have skin-to-skin contact. That's very good. And if you continue to do it on the NICU as well, you have a tremendous effect. If you look at the outcome at 6, 12, 24 months of age, and you look at the intervention group, you have much higher scores, even at 5 and 10 years. You see here, and the intervention was skin-to-skin contact, 14 days, 1 hour per day. You don't have any drug which is improving your IQ so dramatically like you have this effect on the skin or by skin-to-skin contact. And now, different topic, parental empowerment. I was asking you how many of you have some psychosocial support in your unit, which improves parental empowerment. It was about 1/3, if I remember correctly. And I want to explain to you why I think that's very important. There is a very nice data from the Melbourne group, which looked if you have a mother-infant transaction program. That means if you have a special dedicated program to parents, where parents learn to know signs of their preterm baby, then you have actually very good long-term outcome. You have more 10 IQ points more at an age of 9 years. And you also have better morphological outcome. So if you train the parents, you have improved microstructural development of white substance in the baby. I was very much surprised to see these data. Just by training the parents, you have an impact on infant's brain. It's just the opposite of the first data I've shown you. If the mother has stress and is still pregnant, then you have a negative impact. If the baby is born too early and you train the mother, you can also have a positive impact on brain development. And that's amazing. And so I will show you, there was this question now. If you train the parents, you have improved maternal sensitivity. You have improved maternal competency. You also have more interaction from the baby side, and you have a decreased stress. That has been published. These data are from our group. Coming to the next, you can have the training of the parents by having a dedicated program. But you can have also parental empowerment by having parent-guided rounds. So I don't know who is doing parent-guided rounds in your unit, but there is advantages. So there was a questionnaire there in institutions, and they said, okay, there's an advantage for parents, there's an advantage for team, for students. They were afraid of it prevents discussion, and they were skeptical whether it's manageable at the NICU, and they were skeptic that it could cause prolongation of ward rounds, and it could also cause parental anxiety. That was a questionnaire. But if you have the same questions, if you ask these questions to units which have NITCAP, so which are involving parents, compared to institutions which have not NITCAP, you will see a big difference. You see, and the NITCAP units, they will fully agree that it has advantages for the parents. They fully agree that the advantage of teams. They are not afraid of having, or they think it's of advantage for students. They do not think it's prevent discussions. They really think it's manageable at the NICU. They are not afraid of having prolongation of ward rounds, and they are not afraid of increased parental anxiety. So it depends really on the setting of your unit. And you have to change or maybe you already have this one, but it's important to have a philosophy on the unit where parents are partners. And the importance of parents is well known to everybody. And you try everything to support parents. And there is also always forgotten the father. And that's why I bring another smaller publication where they also looked that's very important to involve the father. And they looked not only on a dyadic relationship between mother and baby, but on the triadic relationship, and it should improve parenting stress. And they compared this one with preterm infants with intervention and no intervention, and compared this with families of full-term infants. And what they found, it was very similar groups. And what they found at 18 months of age, in the intervention group, mother and father had better psychosocial scores. Children, higher full-scale developmental quotients, so they are much better developed. Children have lower scores on behavioral tests. And children are, of course, not significant, but they are even better or similar to the full-term group if the parents received the intervention. And I think that's very amazing. And you have another chance, and so we introduced this one, you can use a diary. We have a diary, which is an app, where parents can enter their pictures of the infant and so on, and they can have milestones. They can look at the growth of the baby, and they have real milestones. And by using this diary, use it in analog form, but now it's a digital form. By using this diary, parents get more self-confidence, parents get more sure and empowered. And so I think that's a very good approach to have this one. And parents, if the mother is using it, she can also share this one with the grandparents, some experiences, and so the entire family is involved. And I think that's very important for development. And now I come to the last part, and we can have a last question. And now we are in the postnatal situation. I just want to have two aspects of postnatal situation. One aspect is a very important aspect, which causes the topic habilitation versus rehabilitation. So I don't know whether you have a rehabilitation clinic, but there was a very nice presentation during the past meeting this year in Toronto, and there was the concept very nicely presented. If you have a preterm baby, which is actually very healthy, then you should support the normal development. Everything we have discussed in the past few minutes, supporting parents and so, that's all, everything with the idea to support habilitation, so the normal development. But if you have a patient where you have a disruption, where you have some injury, where you have some brain injury, IVH or so, then you should also have some very specific aspects of kind of rehabilitation. And that's very important to diagnose and to differentiate between babies which are developing quite nice because they need some support because they have extrauterine situation, and some infants which have stroke or other problems. And one aspect for infants, for instance, with hypoxic ischemic encephalopathy is a rehabilitative measure. And I was looking, because we had some discussion in our unit about it, to just want to share this data on music therapy in these patients. And the rationale is to empower parental bonding without handling of the baby and sharing these personal music. So it's again this music therapy performed by the parents, voice, either live singing of the parents or pre-recorded, or some instrumental music by the parents given also pre-recorded. And so the idea is to empower parental bonding. It's less considered to have a direct effect on the baby, but again, an effect on the parents. And so they were looking at the outcomes, and what they found was these interventions can reduce pain score during procedures. This music therapy improves feeding ability, and it has a positive effect on the amygdala volume. So you remember initially, if parents have stress, amygdala is less well developed. If you can reduce stress for the parents, you have a very nice amygdala. But there were also some signs of concern because infants with PVL, they showed in the study some more signs of stress in complex interventions. So that's not fully understood yet, but in general, it seems as if music therapy has some beneficial effects. And one other aspect, which is always or almost always forgotten, the presence of the father, or the feeling of the father. Let's say the feeling of the father. It's nowadays, at least in Germany, it's getting very common that the father should be present during the delivery. And so there's almost some kind of emotional pressure on the parent, on the father to be present in order to be a good father. But sometimes it also causes stress to the father, and that's very often forgotten. And there's a very nice study which looked at these, and they compared how we can reduce the stress by having an improved design. If we have the correct light, a nice color in the delivery room, okay temperature, then the husband's comfort is increased. And I was surprised to see this one. I mean, that's very easy to perform, to change your environment, and then you can at least reduce the stress of the father a bit. And I want to finish my talk with again, involve the father, invite him. He should visit the baby as his baby as well. And I want to finish my talk with a picture how it looked like 55 years ago. You see here it's a baby which is shown to the father. You see the father here, which is not allowed to see or to touch the healthy baby. And so that was about 55 years ago. That was standard. And I got this picture when on my 50th birthday, because it was my father you see here, and that's me. And so that has changed very much. Thank you very much. If you want to learn more about it, you're kindly invited to Dresden to our symposium. You can see this one. Come to Dresden. We have a topic on psychosocial support. And so I'm now very happy to answer any questions.
Thank you very much, Dr. Ruediger. And I loved that ending as well. It's loving. And also we see the revolution over the several decades also. So that was very nice. Thanks a lot.